friends. A warm welcome to all to the SDG free training session under the title From HIV to Health for All, Accelerating the SDG 3 through Practical Partnerships and Solutions. My name is Cesar Nunez. I'm the director of the UNAIDS office here in New York, and I'm honored to serve as your moderator for today's session. Our focus is on accelerating progress towards SDG 3, ensuring healthy lives and promoting well-being for all ages. Today, we will explore how the lessons and partnerships forged in the global HIV response can inform and inspire broader health solutions. We are joined by a distinguished group of speakers representing diverse stakeholders and expertise from the United Nations. I would like to introduce my co-lead, Werner Overmeyer, who's the director of the WHO office at the United Nations here in New York. My colleague, Bettina Schunter, senior advisor, health system strengthening at UNICEF. Mandeep Dhaliwal, director at the HIV and Health Group at UNDP. Ayman Abdelmozen, technical specialist on sexual and reproductive health at UNFPA. Nasneem Damji, senior policy advisor, gender equality, HIV and health at UN Women. Dear colleagues and friends, all of you, thank you so much for being here with us. Our distinguished speakers bring a wealth of experience from across the UN system and will share insights on accelerating progress towards SDG 3 through practical partnerships and solutions. The session will feature presentations from all these agencies, followed by an interactive discussion with all you participants. As your moderator, I will guide us through the agenda and ensure that we stay focused on these practical solutions and actionable recommendations. I encourage everyone to participate actively. Please share your questions and insights in the chat throughout the session. Your engagement is essential for a dynamic and solution-focused conversation. We have 4 aims today: highlight achievements in health, partnerships, and innovations, share scalable solutions that can be adapted to different contexts, strengthen cross-sectoral collaborations at all levels, and 4th, identify actionable recommendations to accelerate progress towards SDG 3. At this point, I am pleased to introduce our co-lead, Mr. Werner Overmeyer, director of the WHO office here at the UN, who will set the scene for us and provide further context on SDG 3 and the importance of collaboration. Over to you, Werner.
Thank you very much, Cesar, and good afternoon to everybody. As you know, WHO is the custodian for SDG 3, and we remain steadfast in our commitment to work with all partners across the globe to ensure healthy lives and promote well-being for all people everywhere. 10 years through the SDG agenda, and we really have to roll up our sleeves in the next 5 years to make gains across all the targets. As you know, health is a precondition, outcome, and indicator of sustainable development. And there are actually health-related targets in 14 of the goals. We've seen in the last 10 years a move away from communicable diseases to NCDs, which account for 75% of death, together with mental health conditions. But also the emergence of new threats that we will get to a little later, such as antimicrobial resistance and climate change, which indeed require strong partnerships. Today's session is something I look forward to because we cannot implement any of the SDGs without stakeholders and our partners, and to work together with all of you in the road ahead. There are 2 quick examples I want to give you before returning to Cesar. Just today, we in WHO again launched the call for a strong rollout of the new long-acting HIV vaccine, which is now becoming available. And we are also hopeful that within the next 6 to 12 months, we will have the first new TB vaccine that has been developed in the last 100 years. This can never have been achieved without strong partnerships between the UN system, philanthropy, and civil society. Cesar, thank you very much, and I return to you to do for us the UNAIDS presentation.
Thank you, Werner, and thank you so much for those two pieces of news. Definitely, lenacapavir is a game changer, and we're pleased to hear about the WHO's announcement earlier today, and looking forward to that TB vaccine as well. Now, on behalf of UNAIDS, I will now deliver a presentation showcasing the HIV response as a leading example of multi-sectoral partnerships and community-led solution. And this session will conclude with a short video that highlights how these efforts demonstrate the interconnected and integrated nature of the Sustainable Development Goals. Let me begin by, briefly going back to some of the concept of SDG 3. Next, please. SDG 3 addresses access to essential health services so that everyone everywhere can get the care they need without financial hardship. SDG 3 addresses better health outcomes, reducing deaths from diseases like HIV, tuberculosis, malaria, and non-communicable diseases, as well as improving maternal and child health. And SDG 3 addresses coverage that is universal, inclusive, and equitable, leaving no one behind, especially the most vulnerable. But SDG 3 also is about how we organize our societies to protect and promote health throughout education, clean environments, gender equality, and strong communities. You will hear me say a lot about strong communities throughout these few minutes. And this is where HIV response has so much to offer. Next slide, please. As a catalyst for health and development, the global HIV response has long been a pioneer in reimagining how we deliver health. It has taught us that health is not achieved in isolation. It is shaped by laws, policies, stigma, poverty, and inequality. This understanding led to a response that is inherently multi-sectoral, bringing together ministries of health, finance, education, and justice, alongside civil society, communities, and the private sector. It is this collaborative spirit that has enabled the HIV response to deliver some of the most significant public health gains in our time. Since the peak of the epidemic, AIDS-related deaths have declined by nearly 70%. Millions of people are on life-saving treatment, and countries have built systems that have been leveraged to respond to other health threats in the recent past. Yet, these gains are at risk. The global HIV response is facing a serious financing challenge. International funding has declined in recent years, and domestic resources are often insufficient to meet growing needs. Without urgent and sustained investment, we risk reversing hard-won progress and widening health inequalities. Now, going back to the heart of the success, as mentioned before, community leadership is essential. People living with HIV, key populations, women, youth, grassroots organizations have not only been recipients of services, they have been designers, they have been implementers, they have been watchdogs. Community-led monitoring, peer-led services, and right-based advocacy have improved service quality, expanded access, and held systems accountable. These approaches are now being adapted to other areas of health and development, demonstrating their scalability and impact. Next slide, please. I think it's the next one. Next slide, please. There. Let me share a few examples of how HIV response is driving integrated cross-sectional solutions alignment with SDG 3 and beyond. Next slide, please. In Eswatini, integrating HIV and sexual and reproductive health services has improved access for adolescent girls and young women, reduced unintended pregnancies, and increased HIV testing and treatment uptake. In Ukraine, community-led harm reduction programs have not only reduced HIV transmission among people who use drugs, but also strengthened mental health support and social integration services. In South Africa, school-based HIV prevention programs that combine life skills, comprehensive sexuality education, and social protection have improved school retention and reduced gender-based violence. These are not isolated interventions. They are scalable models that demonstrate how health systems can be more responsive, inclusive, and effective when they are co-designed with communities and grounded in real-world needs. Next slide. The HIV response has also shown the power of partnerships between governments, UN agencies, civil society, donors, and the private sector. The joint United Nations program on HIV/AIDS, UNAIDS itself, is a unique example. 11 co-sponsoring agencies working together under a shared strategy with a strong role for civil society and affected communities. At the country level, partnerships with ministers, as I have mentioned, have been important to secure domestic funding for HIV programs. Collaborations with private sector have expanded access to diagnostics and treatment. And although work still remains to be done, alliances with feminist movements, youth networks, and human rights defenders have helped dismantle stigma and discrimination in several settings. Next slides. To truly accelerate progress on SDG 3, we must take the lessons of the HIV response and apply them with urgency and ambition, especially in the face of a growing financial crisis. The decline in international funding has exposed the fragility of health gains and underscored the need for sustainable domestic financing. Countries must prioritize health in their budgets and ensure that resources reach the front lines, including direct support to community organizations. Community-led systems are not a luxury, they are a necessity. Investing in them as a core part of a health infrastructure ensures that services are responsive, equitable, and resilient. We must also integrate services in ways that reflect people's lived realities, protect civic space, and ensure inclusive governance where those most affected have a seat at the table. These are not new ideas, but they are proven ones, and they are urgently needed if we are to deliver on the promise of the SDG 3 and broader 2030 agenda. To close, the HIV response has shown us what is possible when we center people, build trust, and work across sector. It has taught us that health is not just about services, it is about dignity, equity, and justice. Let us carry forward the lessons of community leadership, multi-sectoral collaboration, and financial commitment, not only to end AIDS as a public health threat, but to build a world where everyone, everywhere can thrive. Thank you for the time and listening to these few remarks, and I'd like our colleagues to play the video that we have.
I'm Anna. Let me tell you what the SDGs mean to me. I was born with HIV. When my parents died, my grandmother looked after me. We could not always afford food, but she worked hard to feed us. My grandmother is my hero. She insisted I go to school. I was teased at first, but soon made friends. Today, I'm a nurse and I help others. I wish my parents were alive. They did not have access to HIV medicine. Fortunately, I do. Now, the virus in my body is virtually undetectable, so I cannot pass it on. Meet Leo, my partner. He is HIV negative. He loves and accepts me as I am. And we have been blessed with a daughter, Sophia. I delivered her at my clinic. We just installed solar panels so we have electricity, clean water, and toilets. Oh, here comes my brother Ben and his partner Luke. They adopted Tina, who's HIV positive. It has not been easy for them to start a family. They had to go to courts to fight stigma and discrimination against them. They are moving to the city where they will be better accepted, have jobs, and good health services. We are happy living in our village by the sea. Life is good. I'm proud. We couldn't have achieved all of this alone without our neighbors, teachers, the government, NGOs, and partners. HIV exists, but it doesn't define me and my family. Let's end AIDS together.
Thank you so much, colleagues, for playing the video. And as you can see, this is a graphic format in which we share the we show the interconnectedness of the AIDS response to other sustainable development goals. So it's a video I like a lot. I think it conveys a strong and powerful message. We now turn back to our next presenter. We will hear from Werner, Director of WHO here in New York and co-lead of this session, who will address a central question for today's discussion. What practical partnership models have WHO found most effective in expanding universal health coverage and integrating health systems, especially in low and middle-income countries? Over to you, Werner.
I think you're on mute.
Let me start by saying WHO has 150 country offices and more than 800 centers that we collaborate with across the world, centers of excellence. So this illustrates that the work we do across public health globally does happen in partnership. I want to quickly look back at where we stand 10 years down the line. Of course, the COVID pandemic has set us back tremendously and actually caused a decline of 10 years in life expectancy. It also set back vaccination rates with 2.7 million more unvaccinated children in 2023 than prior to the pandemic. But progress is actually being made despite COVID-19. Global under 5 deaths have reached a historic low, down almost 50% just in the last 5 years. Maternal mortality has also declined, and there has also been marked success to combat communicable diseases. This is, however, being threatened by inequalities and uneven progress. On neglected tropical diseases, 54 countries have eradicated at least one NTD. I spoke about mental health and NCDs, the growing health epidemic we are facing. The pandemic of COVID-19 itself increased the rates of anxiety and depression globally by 25%. Cesar has spoken about universal health coverage, which really is the driver for meeting SDG 3 and is underpinned by a primary healthcare approach. People-centered healthcare is what we call it. 90% of your essential health services can actually be provided through a primary healthcare approach. So if we look at where we are now, despite all the improvements we have made over hundreds of years in public health, life expectancy has increased, we are facing a completely new landscape. I already mentioned climate change, but we also now deal with biodiversity loss, urbanization, demographic change, particularly aging societies, air pollution, conflict and displacement, and humanitarian emergencies. WHO is involved in an average of 50 humanitarian emergencies every single year. So there is a need for us to look at how we deal with the health threats and how we strengthen health systems. This is especially true as we see the approach that we need to retailor to take care or at least stem the tide of zoonotic diseases, diseases that spread from animals to humans. And that is why a One Health approach has become extremely important. There is also the financing problem that we have seen globally, with 3.3 billion people living in countries that spend more on debt interest payments than either health or education. And this is linked to OECD countries already reducing budgets for health by 20% this year and a further 20% next year. So the global landscape for financing is not looking positive. Where do we see gains? Gains where we can partner and do better outside of the normal ODA and support from governments. We see many gains in health literacy, which can be improved, especially among indigenous persons and in traditional medicine communities through AI and through digital applications. We have a global initiative on digital health that we manage with ITU and several partners outside of the UN. And this prioritizes how we can use digital health transformation to increase how we deal success, how we deal with the Sustainable Development Agenda, but specifically how we scale up health interventions in underfunded populations and countries and build their capacity. So this is an initiative. You can read more of it online on WHO's webpage. A good example of it is the Be Healthy, Be Mobile program, which we launched more than 20 years ago. This is something that has been very effective because there are more than 7 billion people that use mobile telephones, of which 70% are in low and middle income countries. So we reach them in terms of prevention programs for non-communicable diseases and also to provide counseling for mental health conditions. We have 2 apps on the WHO webpage, which I want to actually recommend all of you use. I myself have checked it. It seems to be working very well. There is a HEAR, HEAR WHO app, where you can go and check your hearing. And this is something that we find very, very helpful at community health clinic levels. And then there is also an app where you can check your vision. It is called WHO Eyes. Very important because 1 billion people in the world have eye health conditions which are entirely preventable, but they are unaware of it. So those are 2 quick examples where I think we can partner with many of you who are in the field with us and doing work that are very supportive of WHO's core priorities. I thank you very much and look forward to speaking to you a bit more if there are questions. Thank you, Cesar.
Thank you so much, Werner, for that, for those remarks and sharing about the work of WHO and its leadership and you know, in moving forward as SDG3 in support of the member states' work. It's very interesting that you closed with reference to technology and the use of AI and this couple of apps on hearing and sight, because coming up, our next speaker from UNDP, Mandip Dhaliwal, will highlight how digital tools and artificial intelligence are opening new pathways for more resilient and effective health systems, particularly in resource-limited settings. Mandip, over to you.
Thanks very much, Cesar, and pleasure to be sharing this webinar together with you and Werner and colleagues from UNFPA and UN Women. The first slide, please. So really just to start by saying that UNDP really leverages its mandate in governance, poverty reduction to address the determinants of health. So we are not necessarily the people that are focused on the health sector per se, but we are focused on all the factors that influence health and access to health services. And that's really where we come in as the development actor. So go to the next slide, please. So just a little bit about the context. You heard about this from Werner. Climate change is really, if it's everything from accelerating extreme heat to the severity of flooding and weather events, it's increasing global health risk. We have more and more conflict, which is leading to more fragility, with a quarter of the world population living in fragile or conflict affected settings. The risk of future pandemics is rising. We've got shifting disease epidemiology. You heard from Werner about NCDs. Even people living with HIV who are living thanks to antiretroviral treatment, more and more are contending with, as they age, contending with NCDs. We still have, even with the incredible progress we've made, for example, with HIV treatment, and you heard about the new highly effective prevention technology for HIV, we still have very, very persistent innovation and access gaps, particularly in low and middle income countries. And finally, the question that is very much on our minds, the declining overseas development assistance, which has been declined 9% this year, and next year is set to decline by 17%, in addition to more abrupt health financing disruptions, really putting a lot of burden on countries. And then, of course, there's COVID-19, which has really, in addition to reducing life expectancy, also put tremendous pressure on countries' fiscal space and their capacity to invest in health. So we're in a tough time. The context is challenging, but in every challenge, there's also some interesting opportunities. The next slide, please. So just to tell you a little bit about our work on SDG 3, and I was really happy to hear mention of the other health-related targets and the other goals. So just to tell you a little bit about UNDP, we work in health in over 100 countries. Our partnerships with WHO, UNICEF, UNFPA, and others, Global Fund, Gavi, the World Bank governments, we're the founding co-sponsor of UNAIDS. We worked on HIV before UNAIDS existed, focusing very much on governance, rights, and law. Our role is very much about connecting the dots across different sectors. Cesar mentioned multi-sectoral. Our role is really to connect the dots across the multiple sectors and work in a multi-sectoral way. The work contributes to our core mission of tackling poverty and inequalities and building resilience. And the two areas that I really want to focus on today are about how we promote effective and inclusive, it should be, governance for health and health equity, and building resilient and sustainable systems for health and health equity. The next slide, please. So I did a little scan of the VNRs for this year. And we're seeing progress on expanding health coverage, also progress on maternal and child health that countries are reporting. More and more countries talking about digital health, which is interesting, and concerns around mental health, NCDs, aging populations, demographic issues, and trying to sort of cast off sort of some of the negative impacts of COVID-19 and building forward. On digital and AI, it's interesting to note that the VNRs really focus more on digital economy and broader development goals, less specific on digital and AI for health. So I think there's a real opportunity for us to be doing more with member states on that. Where they do talk about health and digital and AI for health, the focus is very much on service delivery. So for example, in Ghana, it's about health services. In India, it's about the national scale up of EVIN and COVIN, which were digital apps for vaccine cold chain management. Israel also talks about digital, but notes the issues around mental health. So there are real opportunities for us to scale digital and AI for health, for greater health equity and development impact. One thing that we need to be intentional about, just linking back to the context, is the links to climate and environment and pandemic preparedness and response, and really looking also at mental health issues around AI and digital, especially for young people. And I encourage, I'll put the link in the chat, but I encourage you to look at UNDP's flagship Human Development Report this year, which is all about harnessing the potential of AI and has some quite concerning findings about mental health, young people, and AI. So the next slide, please. So lessons and tools. I mean, I think there's some very clear lessons, which, also are relevant, also have emerged through the HIV response about the need to invest in local capacity. So that's capacity of the formal health sector workforce, but also the community health workforce. We see the value, particularly in the digital and digital health governance space, of first piloting. For examples of India and Indonesia, you can go to the UNDP Digital Health for Development website and see how a digital application has been piloted and then scaled up. Very important learning. And in addition to that, really investing in the local capacity in terms of regulatory and governance actors and institutions. So it's not just about investing in health capacity, but also the regulatory capacity. We need to embed human rights and ethics in the policy capacity building and implementation. That's how we're going to get good governance of digital and AI for health. Data governance is a major issue, privacy, confidentiality. A lot of countries don't have what's needed to protect health data or data more generally, very important. Another major issue is the need to use open source tools and goods, things that are interoperable, that are scalable and affordable. Cross-sectoral community and citizen engagement is critical. And we need to think about embedding all of this in digital and energy transformations. We all know that AI has incredible energy needs. So the more AI you run, the more energy you need. So we need clean energy, renewable energy. You need an energy transformation if you're going to scale up AI for health. There's lots of incredible work being done in low and middle income countries, and that South-South collaboration and learning is very, very important. And also, as is the cross-sectoral and innovative approaches and alliances, which both Cesar and Werner have talked about. Let me go to the next slide, please, just to give you an idea of what some of this looks like. You can find all sorts of information on what I've talked about in terms of digital health for development. And it's all on this hub that UNDP runs, which includes the tools, not just of UNDP and the countries we work with, but also the tools on digital health from WHO normative guidance, on scaling up digital health and AI. As a matter of fact, we work very closely with the digital health team at WHO on all this work. The hub will give you resources on technical and advisory services, capacity development, South-South collaboration, as well as knowledge, leadership, and management. The next slide, please. And just to give you an idea of the kind of scale, we are supporting work and working with partners in over 90 countries on digital health, and this includes things like sustaining health services in fragile and conflict-affected settings, strengthening pandemic preparedness through scalable digital infrastructure. India and Indonesia are fantastic examples of where we have been able to rapidly scale up, including during COVID. And it was UNDP and the government of India's electronic vaccine management system that was rapidly scaled for the COVID vaccination in India, where we were able to help the government vaccinate over 1.2 billion people. Similarly, in Pakistan, we have an application which is being rolled out through our partnership with the government and the Global Fund, which helps reach marginalized populations like men who have sex with men with access to health information and health services. PPR, very good question, pandemic preparedness and response. Sorry about the acronyms. The next slide, I'm just racing so I can get through time here. But just to give you an idea of the vast kind of array of tools and stories and things that you can learn from that are on the Digital Health for Development website. This is just a quick snapshot here. And I just want to make this point that digital tools are as valuable, if not more valuable, in crisis and conflict-affected settings as they are in more stable settings. So we should really be looking at that. Another point is that we need to really deploy these tools in a way that does not increase the digital divide. And what do I mean by digital divide? So there's a gender divide when it comes to digital. We want to make sure that we are intentionally reaching women, reaching young girls, so that we don't exacerbate the inequality there. We also want to make sure that what we're doing is part of the overall digital transformation in a country. The next slide, please. Another sort of example of, could we get the next slide? Yeah. And this is the last one, but just to give you an idea of the kind of tools that we're talking about. One of the lessons that I think is really, really important is to make sure that in the work that we're doing, we are embedding human rights and ethics in the use of digital technologies and the use of AI. There's a very good guidance that we've developed on the use of these tools in HIV and health programs, which you'll find on the website, looking at ethics and governance also. Again, so there's a vast array of tools out there already. We've attempted to collate them here, so please do use them. And you can reach out to us at the website for anything more. And I'll stop here now. So the real lessons are around embedding ethics and governance, community engagement in the governance for digital and AI for health. It's possible. Being intentional so that we are not increasing inequalities and increasing inequities when it comes to populations and when it comes to access to the kind of broader tools that are essential, like energy. And I'll stop there. Thank you, Cesar.
Thank you, Mandeep.
And the presentation's available for people. I'll put stuff in the chat as well.
It's been a wonderful walk through all of these opportunities and actual work that is going on in terms of applying artificial intelligence technologies to strengthen health systems, governance, and accelerate process. Very opportune, your comment towards the end about the intentionality of of how we proceed in strengthening, and also your point about investing in local capacity with a particular attention to data governance, privacy, confidentiality, and so on. So issues that are so common and now with so easy access to devices by youth, making sure that is also done in the most horizontal way possible. We'll hear more later, and I know that there was a question about PPR that Mandeep already replied, and we understand that we have a varied audience, so please ask questions. If you hear something that does not sound that you know what it is about, just put a question in the chat. Regarding the apps, there was a question to Werner. They are in the platforms, either Android or iPhone. Maybe that can be, Werner, you can put the actual name of the apps in the chat. So it's now my pleasure to welcome our colleague Bettina Schunter from UNICEF. UNICEF has been a leader in driving integrated and transformative programming to improve health outcomes, particularly for vulnerable populations. In this presentation, I invite Bettina to highlight a successful example where cross-sectoral collaboration has led to transformative health results for those most in need. Over to you, Bettina. Welcome. You're muted, Bettina.
Thank you, Cesar. Can you hear me now?
We can.
Great. So good morning, good afternoon, colleagues. UNICEF is grateful for the opportunity today to share with you some findings from our adolescent peer service models in Eastern and Southern Africa. So I'm going to drill down a little bit from the last presentations and look specifically at these models and the outcomes they've been able to achieve across different targets of the SDG 3. Next, please. So while we have achieved much towards reaching SDG 3, adolescents, especially girls, remain behind, with many of their critical needs still unmet, notably in sub-Saharan Africa. Adolescent girls are still disproportionately affected by HIV, but also by early pregnancy, sexual violence, low rates of completion of secondary school, living with mental health disorders, and lack of access to the formal job market, which you can see on the slide here. Next. And I will share these slides. Next, please. So back, please. I just want to sit on the slide for a sec. There's increasing evidence that young people are driving change and having a positive effect on the health and well-being of their peers, and that many peer-provided interventions demonstrate results across multiple SDG target areas. Increasingly, we have seen that these models are not peer educator models, but peer providers with skills and responsibilities beyond just sharing information. Their power is the coming alongside their peers, listening, asking questions, sharing information, most importantly, sharing experiences and supporting them. So UNICEF's call to action is investing in young peer community health workers. We have seen their power and success across social sectors, and we are committed to seeing these interventions have greater impact and, most importantly, go to scale. Next, please. Since 2018 in Eastern and Southern Africa, UNICEF has been focusing on improving and demonstrating outcomes for adolescent and young mothers through these models. We have different adolescent delivery models across the globe, but the ones in ISAR, we have been gathering the most program-based evidence. Outcomes related to education, mental health, well-being, contraception, safer motherhood, income generation, HIV testing and treatment uptake, and retention. We have seen increased and improved outcomes in all of these areas. The models did start as HIV specific, for example, for HIV positive adolescent mothers, but now have increased to adolescents in general, primarily adolescent girls, given their unmet needs. Currently, UNICEF is supporting peer models for adolescents and young mothers under the Together for SRHR with UNFPA, UNAIDS, and other partners in 9 countries. And we're going to scale and integrating international workforces in 3, South Africa, Uganda, and soon Zimbabwe, which is great. Next slide, please. The transformative models also improved incomes for children of young mothers and young fathers. For the children, improved outcomes related to birth registration, immunization, early childhood stimulation, early infant diagnosis of HIV, and initiation of treatment. And for the young fathers, improved outcomes related to a decrease in intimate partner violence, improved relations, and uptake of HIV testing and linked to treatment and prevention. Next, please. And next. So how are we improving? What have we seen? Looking at the lessons learned from current implementation, we realized to make the required impact on the outcomes of adolescent lives, we absolutely need to move beyond pilots and boutique programs to scale, as mentioned by Cesar. We have learned many lessons from the implementation of programs UNICEF has supported about how we get to scale, how we program at scale without compromising quality. Scaling efforts have included a strong focus on government and community ownership, updating of government policies, and leveraging domestic resources and large donor investments, especially the Global Fund. A key aspect has been the requirement of evidence. And as presented, we are seeing a growing body that is demonstrating impact. This evidence has been instrumental for leveraging funds and inclusion of peer providers in national policies, plans, and workforce. Lastly, UNICEF HIV and education sectors within UNICEF are conducting a costing analysis of the peer-led model. There are early indications that peer and human-centered service delivery model for adolescent girls is actually cheaper than delivering services through traditional facility-based models. So this data will be available later this year. Next, please. I think we've all seen similar demographic information. The African continent is young, it's getting younger. By 2030, Africa will have the largest workforce population, and by 2050, more than a third of their population on the continent will be young people. Or rather, sorry, a third of the world's young people will be living on the continent. The potential of Africa's young people is very exciting, but there's much to do to ensure the potential is reached. So a critical aspect of UNICEF's current work and thinking is looking beyond the impact on the beneficiary, but also the impact and what is required for the young health workers themselves. What skills have they developed? How can they be supported in their roles? What are the system requirements? Understanding this is important for us in health and also important for those who are investing in young Africans' skills and job development. Health systems in the ESAR are under-equipped. The workforce shortfall is estimated in Africa to reach 6.1 million by 2030. So there's an opportunity here for young people to join the health workforce formally. As global efforts continue to consolidate and improve community health workforces, like through the Community Health Delivery Partnership and the Global Fund, we must consider and capacitate the youth health workforce, including equitable pay, quality education and training, and a safe working environment so they can provide the care on which their peers and communities depend. So through this effort, we'll help to reduce gender equality, strengthen community systems, and accelerate progress on universal health care and the targets under SDG 3. Next, please. Lastly, I just want to share with you some guidance that is coming out with Together for SRH, University of Cape Town, Oxford University to better support implementation. So this group is working together to update and expand the body of knowledge on peer models of service provision, where much of our data has come. Through looking at the latest published literature and gathering program insights, we're improving our understanding of how-to of peer provider approaches, and that is what is included in this guidance. And it's also looking at the experience and perspective of peer providers for gaining understanding of their skill development and importantly, career trajectories. So that is it. That is the work we are doing in ESAR with young mothers and their partners. Thank you very much.
Thank you so much, Bettina, for sharing this summary. Evidently, I pretty much appreciated the reference to the future of the workforce and young people. Very, very pertinent topic as we realized that the numbers are limited and have been limited for a long time. Obviously, when you started, also how adolescents remain behind, and particularly women, in addressing all the issues. You are probably the fourth speaker who has also brought the issue of mental health. And it's important that we keep this in mind. Usually when we refer to health, we tend to leave mental health outside. And thank you for having brought that in your presentation, Bettina. So let's shift now our attention to the vital area of sexual and reproductive health, gender equality, and reaching marginalized groups. I'd like to invite our presenter from UNFPA to share practical approaches and recent initiatives that are making these essential services more accessible and responsive, particularly for those facing the greatest barriers due to discrimination, social norms, or provider bases. Amen. We are all ears. You have the floor.
Thank you, Cesar. Good morning, good afternoon, good evening, everyone. And it's a pleasure to be part of this esteemed team of presenters. And actually, I'm going to take advantage and benefit from much of what Mandeep and Bettina have mentioned in their slots before me. So I'm going to speak a little bit as of the importance of integration, of the provision of the integrated sexual and reproductive health and gender equality aspect to be able to achieve the SDG goals. So if we can go to the next slide, please. And the next slide is mostly, okay, well, the next slide is mostly speaking a little bit or reminding ourselves about the severity of the problem, which much of this was mentioned by my previous presenters. I just want to highlight a few points when we're looking at this slide, and of course we can share the slides. When we are looking about the fact that realizing sexual and reproductive health and rights, how they are unrealized, if we just looked into one piece of evidence that shows that an African woman experiencing pregnancy and childbirth complications is 130 times more likely to die from them than a woman in the West. And when we dig deeper into this, we'll find that almost 250 million women still lack access to modern contraception. And simply because half of them cannot make informed decisions about their sexuality, their sexual health, the timing of their pregnancies, when do they want to get pregnant, what kind of services they would like to get, and so forth. And of course, I don't want to highlight most of us know that the risk of maternal death is 8 to 20 times higher in women living with HIV as compared to those who are not. So in order for us to be effective, in order for us to reach the targets of SDG 3, we need to look very, very much into how we can provide an integrated service to the woman and how we can make this service a woman-led and woman-reflective package of services. So let's move forward to the next slide, please. Rupa or Cesar. Okay, so our approach at UNFPA is to adopt a woman-centered approach. So what we have done is we have come up with a new strategy, and we call this strategy Start With Her. And the very important aspect in this strategy is that we are changing the direction of action from a service provider or service delivery centered approach into a woman-centered approach that identify the collective sexual and reproductive health needs of the woman. If you as old as I am and you started with development more than 30 something years, we lived in an era where there were some family planning interventions that are parallel to some maternal and newborn health interventions. And then when HIV showed up, there was a separate line. We had this siloed vertical approach to services that was not catering enough to the woman's need. A woman's sexuality is a woman's sexuality. We cannot separate one service to the other. That's why it is very important for us to reflect that we need to, we started working into empowering women to have the right to decide if and when she wants to have children. That's why we stress upon starting with her. When we look deeper into the starting with her, we will find that when we look into her sexual and reproductive health needs, integrated maternal and newborn health and well-being within the rest of the package of sexual and reproductive health is critical for and should be a main pillar in universal health coverage. And this is how we have started shifting our approach under our current strategic plan and our new strategic plan. Another element that I wanted to highlight is the fact that we are living now in an age where if we look around, we'll see that there have been significant improvement in the collective data that relate to sexual and reproductive health. However, again, if we dig deeper, we will find that there are so many discrepancies and gaps between those who are well served and those who are not served. So that's why it is very important for us not to look into the environment or to the clients that we're serving like one solution fits all. We have to focus on leaving no one behind. meaning that we need to focus on the personnel, the financial resources, the physical, mental, and financial access to these services. And we need to invest more into those who are undermined versus those who are served, which brings us, as we move forward, when we are focusing on improving access to HIV prevention and treatment, we need to invest further in those who are left behind. We need to invest further into adolescents. We need to make sure that sexual and reproductive health agency is given to all. And then we can do this only by making sure that more investments are made to these key populations and those underserved populations. When we look into these key populations, we'll find that it is not just a matter of lacking access to service. There are so many socio-cultural factors, especially discrimination that is based on age, disability, ethnicity, sexual orientation. All of these factors are cultural and social factors that hinder against access to the service. So when we look into an integrated universal healthcare approach that ensures equitable access to SRHR, we need to look into how we can make sure that those underserved communities are being served. Next slide, please. This is an example of Ethiopia, what we do in Ethiopia, for example. And I'm not going to go through all of this, and because of the lack of time, I just wanted to highlight that our main aim is to work at the policy level, to work with governments, to work with the non-governmental sector and private sector to make sure that the policies there are conducive to the effective delivery of integrated services. What we've been doing with Ethiopia, for example, is we've been investing more into an integrated midwifery-led care model that is built on evidence that ensures that midwives are existent, are available and employed and deployed and motivated enough to develop an integrated SRHR approach, which is part of improving equitable services in SRHR across the country. And this is what we've been doing, in addition to us providing the essential maternal newborn health services and, of course, contraceptive services. So we also focused on improving community-based work because, again, going back to my previous slide when we are highlighting leaving no one behind, it is very important to concentrate on and invest more on community-based interventions. And this is something we've been achieving significant strides in Ethiopia that have considerably improved equitable access to these services. I'm not going to belabor on this, but this is one of our examples that shows you the different levels of interventions that we've been implementing in one of our countries that we serve. Next slide, please. So the priority for action from our side is basically working on the legal and policy reform and all of the policy, the fiscal, regulatory, and other and service delivery policies that regulate the delivery of services, especially when it comes to domestic resource mobilization, when it comes to integrating the service delivery models that is dependent on the new midwifery guidelines that we've been working with WHO. These are among the policies that we've been working with governments on. We've also been working with governments on policies that relate to the importation and the distribution of essential reproductive health commodities, especially contraceptives and essential maternal health commodities. As I mentioned earlier, we also focused on strengthening the inclusive participation of country-led community levels that ensure that there is an integrated total market approach when it comes to the delivery of services, and of course, embedding sexual and reproductive health within the national health system to ensure that universal health coverage is inclusive or aspect, informative service delivery and mental aspects of sexual reproductive health and rights, and there is no discrimination and there is no lack or discrepancy in the services that we provide. And of course, we do all of this by investing in data and evidence to make sure that we are data-driven so we can focus our resources that are getting scarce by the time. I'm sure everybody knows that. So we need to be very much focused. We need to have to pinpoint where we can have the best impact by our investments. So we invest more into data and evidence. So this is my few words, which is, again, we can move to the next slide, please. And yeah, so that is my short words, and I'm happy to answer any questions at the end of this session. Over to you, Cesar.
Thank you, Aylan. You must have felt I was going for the button again.
Okay.
Thank you for your remarks and teachings to all of us. Certainly, UNFPA on a woman-centered approach. I liked your mentioning of a Start With Her program, and certainly UNFPA's approach to the collective SRHR needs, serving the underserved populations, investing further in adolescents, and so on. And of course, similar to what UNDP was saying, involvement in the legal and policy reform, particularly on the regulation of the delivery of services and procurement of maternal health and commodities. So we have seen a bit of a bridge with UNFPA. We heard Bettina talking about adolescents, young people, and you brought some angles of the work with young people, but also with women who also include young people. And then I have now the pleasure of inviting our dear colleague and friend, Nasneem Damji from UN Women, who I would invite to talk to us about key elements of successful gender-responsive health solutions, and how can these be mainstreamed across SDG 3 partnerships. Welcome, Nasneem.
Great. Thank you so much, Cesar. And I will be probably reinforcing a lot of what colleagues have already said. It's a great pleasure to join you today to talk about how we can be accelerating progress on SDG 3 through gender-responsive solutions. I just want to remind colleagues that we are also commemorating the 30th anniversary of the Beijing Platform for Action. We reflect not only on the progress, but also on what's ahead of us. The Beijing Declaration was a bold promise to all women and girls that their rights, their dignity, and their health would be non-negotiable. Yet 3 decades on, its vision remains a bit unfulfilled. We do have, however, ample evidence that health systems that ignore the unique barriers faced by women and girls are not only unjust, but they're also ineffective. So that then in turn hampers progress towards both SDG 3 and SDG 5 on gender equality. So just to remind, gender equality and women's empowerment are not optional. They're essential to achieving all the Sustainable Development Goals and the promise to leave no one behind. You've heard some of the data, but I'll reinforce some points here. When women and girls are denied access to healthcare, the ripple effects are felt across entire communities. So today, women and girls continue to face systemic barriers to their right to health, driven by entrenched gender norms, by economic exclusion and discrimination. As you heard from UNFPA, only 56% of married women aged 15 to 49 can make decisions about their own reproductive health. This is a stark reflection of the structural inequalities and the harmful norms that deny women agency over their own bodies. We also heard from WHO about the maternal mortality declined between 2000 and 2020, but we have to insist to share that also progress has stalled. Every day, over 700 women die from preventable causes related to pregnancy and childbirth. That's nearly 1 woman in every 2 minutes. Indigenous, poor, migrant, and minority women face heightened risks during pregnancy and childbirth and are less likely to receive quality care due to discrimination and mistreatment. Also, as we heard earlier, in 2024 alone, 210,000 adolescent girls and young women acquired HIV, which is equivalent to 570 new infections every day. Gender-based violence remains pervasive with devastating consequences for physical and mental health. And the recent funding cuts, particularly to community health responses, really threaten to reverse the hard-won gains. But the good news is that we know what works. First, women must be meaningfully involved in shaping the policies and services that affect their health. UN Women's Power Program in the Horn of Africa supported women's and adolescents' reproductive rights by expanding access to information, resources, and community support for sexual and reproductive health. In Ethiopia and Uganda, power clubs enabled women and adolescent girls to co-create solutions, from income-generating activities to community dialogues, and all of these improved their access to essential health services. The second point I want to raise is that data must drive our decisions. We heard a lot from UNDP about what needs to be done in terms of that, but I just want to share also that health strategies must reflect the lived realities of women and girls, ensuring that inequalities are identified and addressed through targeted actions, budgets, and accountability. Third, gender-responsive health strategies must be integrated across sectors. Whether a woman can reach care, afford treatment, or escape violence is really shaped by her economic, legal, and social environment. So when maternal health programs are paired with cash transfers, with legal protections, and rights education, the results are transformative. In Ethiopia's Gambela region, UN Women's Power Initiative mobilized over 15,000 men to champion women's rights and improve access to care. Fourth, we must also significantly increase investment in proven women-led solutions. Too many effective models remain underfunded. The UN Trust Fund to End Violence Against Women, which is a multi-partner trust fund, for example, supports grassroots organizations working with women living with HIV, with women who use drugs, with sex workers, and empowers them to demand access to non-discriminatory legal aid, HIV care, and other essential services. And then finally, women must lead. Although women make up over 70% of the global health workforce, they hold only about a quarter of senior leadership roles in the health sector. That has to change. Policies that reflect women's needs have to be shaped by women's leadership. UN Women's Leadership Programs in Sub-Saharan Africa have mentored young women to influence national HIV responses, proving that when women lead, change follows. We really want to take a moment now to call on all of the stakeholders to take bold action to accelerate progress towards SDGs 3 and 5. The Beijing Plus 30 Action Agenda that was launched at the Commission on the Status of Women earlier this year urges countries to invest in social protection and quality public services, especially in women's health, girls' education, and care, and this will dismantle inequalities and help to drive progress across all SDGs. So just to quickly sum up, to deliver on the promise of Agenda 2030, we must focus on 4 interconnected priorities. First, invest in gender equality and women's empowerment, not only because it leads to healthier, more resilient communities, but it is a fundamental human right. Second, design gender-responsive health systems. One-size-fits-all approaches fail to meet the specific needs of women and girls, or men and boys, and gender-diverse populations. Health policies must be grounded in gender analysis and tailored to address inequalities in access, quality, and outcomes. Third, elevate women's leadership and strengthen partnerships. We've heard a lot about the kinds of partnerships that are really delivering for SDG 3. So I would just reinforce that these partnerships need to be critical and important for women and girls being the center to shape the policies and systems that affect their lives, not just beneficiaries, but also as leaders. And fourth, we really absolutely have to challenge harmful norms and practices. Discriminatory practices and gender-based violence continue to undermine health, rights, and development, and addressing these root causes is essential for lasting impact. This is a pivotal moment for global health and gender equality, and achieving gender equality is not just a goal, it's a foundation for health, for dignity and justice, and a strategic imperative for sustainable development. So, to close, by aligning our investments, our policies, and our partnerships, we can drive measurable progress and be building more inclusive, resilient societies. Thanks so much, Cesar. I'll pop some links into the chat to share where we have more details on our POWER program. Thanks so much.
Thank you so much, Nazneen, for that summary. And certainly you brought up an important element, the intersecting inequalities, women indigenous, women living with HIV, women who are young. And sometimes we have this combination of a woman who's indigenous, who's also a key population, and so on. Also, all of these comes on top in terms of the inequalities. Gender-based violence as a as an important variable in addressing the participation of women and young women. And certainly, I think that we have also touched, all of us, on the importance of investing in those populations that have been left behind. We have just a few more minutes before the end of our session. And I want to remind everyone this has been a workshop, so it's actually conveying information and trying to engage our participants in learning about the work that is being done to streamline SDG 3. We have a full week, this and the following. We're going to listen to member states, 37 of them, if I recall well, telling us about how much they have done in terms of the implementation of Sustainable Development Goals 3, 5, 8, 17, and I think I'm missing one. But is there any question from the audience? You may want to raise your hand. And to indicate that you would like to take the floor. I know that there were a couple of questions in the chat that were already responded. If not, I'd like to give a 1 minute to each of the different speakers to say their closing remarks, if possible. Can I start with you, Werner?
Werner has left.
Oh, I believe that he has stepped out. Can I continue in the same order? I believe it was Mandeep. Maybe she also left. Yeah. Okay, so let me see. Is Bettina online?
Yeah, I'm here.
Okay.
Yeah, thanks so much, Cesar. I don't really have a lot. I just think that it's really important to point out that all the presentations put community first and community led. And I think that in this era and context of declining funds, that it is the community that will bring the greatest results on the targets under SDG 3. We cannot scale up without them. And the other is, let me just leave it there. Thank you so much.
Thank you, Bettina. You're spot on that one. I can see Mandeep now. Mandeep, 1 minute for just any closing thoughts that you may have.
Yeah, I mean, closing thoughts, first of all, I mean, the HIV pandemic is not over. So there's still a lot to do. And I think, the UN system across the 11 co-sponsors is doing a lot. And I think what we each do as co-sponsors is really, really relevant to what needs to be maybe not in the same way in all places. So I think kind of a coordinated multi-sectoral response remains really, really important, but it needs to look different than what it did 3 years ago or 5 years ago. That difference is super important. And I think, using new tools and technologies, super important. The role of communities, super important, both for HIV, but for SDG 3 more broadly, and the health-related targets in the other goals. So the innovation, the science is there, the evidence is there. I think what we have is a scale issue. We need to be scaling up, which remains really, really critical. And communities are a huge part of that answer, as are governments. And that is where I think we need to really play an important role, that governments are working together with communities in the way that has helped to really define the success of the HIV response over many, many years. So I'll stop there. Thanks.
Thank you, Mandeep. Ayman?
Cesar, thank you. I don't think I have more words of wisdom after what's being said, but because I have the floor, I would like to highlight what we all know, that resources are getting less and we have to work together. At the same time, and Vermeer mentioned it in his very beginning, There are so many interesting and exciting innovations that are coming on board. We need to put our hands together to work together to improve access of these innovative technologies. He's been talking about the vaccine. Let us work together in making sure that the vaccine is accessible. There is now the long-acting lenacapavir. Let us work together in making sure that there is a universal access to it. Let us, within our very tight funding situation, we will have to prioritize and we will have to work together. Otherwise, we're going to be wasting the very, very dear resources that we have around us. So let us focus on this. Let us keep on working together in identifying the priorities, and let us make sure that prevention and treatment are almost everywhere before we lose control of the situation. Over.
Thank you so much, Ayman. And Nazneen, your final wisdom.
Thank you so much. I couldn't agree more with what Ayman just said. I think it's critical that we have collaboration, that we have engagement together and drive solutions together. I would say only to add that we have to remove some of the barriers, and we are leaving people behind, and we have to recognize that, and we have to address that urgently. Thanks so much.
Thank you, Nazneen. And I'd like to give my deepest gratitude to all of you who I know that took time away from your daily activities. Thank you for sharing with colleagues who connected today. We had up to 90 colleagues connected, which is a good size, even beyond what we could have gotten in a conference room. And the session was recorded, so there, it can be used further. I want to also express my appreciation to Rupa, who was running the show behind curtains and made sure that we had everything prepared. To our colleagues at Unitar, who have been managing the Zoom connection, and to the office colleagues here, Nainan in particular, who was reaching out and working with all of you. So much work into making sure that we tell colleagues interested in seeing how much we have advanced and how much we still have to do to achieve SDG goal number 3. I was listening to some decision makers who have the money strings in their fingers, saying that research was expensive, that science was expensive. I believe that somebody said that think about illness. That is more expensive. So with that, I close and I thank you all. I wish you having a good day. Thank you all who participated online in this session. Have a good afternoon.
Thank you very much.
Thank you so much. Thanks, Cesar. All the best.